My name is Stefan Baldus. I'm head of the Department of Cardiology at the University Heart Center in Cologne, and I'm focusing on catheter treatment of structural heart disease. So aortic valve disease as such is highly prevalent, and it's driven by aortic stenosis. However, we've seen that a good fraction of patients with aortic valve disease have not only aortic stenosis, but has mixed disease, so accompanying aortic regurgitation. And we also know of a not significantly low number of patients which has pure aortic regurgitation, so non-calcified valves with significant aortic regurgitation. And what we have learned is that these patients have a miserable prognosis. They have a not normal prognosis, and these patients have been neglected and have been refrained from therapy over a long period of time. So the current treatment options for patients with severe aortic regurgitation are basically exclusively and have been exclusively surgically. So replacement or reconstruction, surgical reconstruction of aortic valves is and was the therapy to go. However, we know that patients with this disease are typically elderly patients and patients who have an increased surgical risk. So we see that only 10 to 20% of patients with severe aortic regurgitation actually undergo surgical treatment. So we have a large proportion of patients who is not undergoing equivalent treatment. If we think of transcatheter therapies for this disease, the conventional valves are typically not suitable to treat these patients, given that transcatheter treatment needs calcification to hold the prosthesis in place. And this is the current challenge we face for the treatment of pure aortic regurgitation. So given that the design of the self-expanding as well as balloon expandable transcatheter valves is not suitable, is not ideal for the treatment of pure aortic regurgitation, JenaValve comes into place and has a central potential in this cohort of patients, because the design of the prosthesis is entirely different to what we've seen so far, in that it is clipping the native leaflets towards the new prosthesis, rather than using radial strength to keep this prosthesis in position. And this is unique, and this makes clear why it's not necessary for JenaValve to rely on calcification for safe positioning. And this is why we believe that this valve has the potential to be a very important, a central treatment option in future for patients with pure aortic regurgitation. What we need to establish JenaValve as an important and central, and potentially for a subset of patients, first-line therapy in aortic regurgitation is larger registries where we can document safety and efficacy of this treatment as we have seen it in the patients treated so far. And perhaps in the long run, I'd like to see a randomized trial where we are randomizing patients with aortic regurgitation to surgical therapy or a JenaValve. So in patients who can be treated, perhaps at elevated risk, can be treated surgically, these patients should be randomized to a transcatheter alternative or surgical therapy in order to see whether there is non-inferiority or potentially even superiority of this treatment option for patients with this disease.